But firstly, we have to discuss are cases which are presented in your tickets. If you pay attention today at these questions, you will find that all of them are included in your exam tickets. That's why if you listen it in a proper way, you will easily solve the last question of your ticket. The style of the exam session will be in next presentation. You know that firstly, you have to go through the central testing, how we call it in Russia, or MCQ, how you call it in other worlds. According to this, in the proper day of your test, you will find the blue button at your profile, and you should press at this button, and you will be redirected to the web page dlsechenov.ru, where you have to solve these tests. In the test, you will find the proper task. What should you do? It can be like, please choose only one proper answer or choose many answers. If you see that it should be only one, you shouldn't choose more. If you see that it's possible more than one, you need to choose all you think are proper. After that, if you pass your test, you will get your satisfied or unsatisfied mark, and according to the levels of the acceptance, if you pass for the satisfied, good, or excellent mark, it means that you have the acceptance to the oral part. If you pass your test for unsatisfied mark, it means that you have no permission to pass the oral exam. After that, in another day, you will additionally find this information in your profile. You will have the blue button, which will direct you to the oral part of our exam. The style of the exam is that you have 10 minutes for your answer and you have 20 minutes for your preparation. If you do not pass your exam in time, so each of you will have 10 minutes for the answer. If you do not answer during 10 minutes and you need more, the examinator or the system will cancel you and you will have no ability to answer nextly. So you need to prepare your answers in a very short versions. If you see the question like a topography of the shoulder joints, you need to speak only about topography. So to discuss borders and layers, you do not need to explain that it can be located somewhere in the upper part of the body. No, you only wasting your time. So once again, you speak only about question. You need to have the microphone and camera in your computer, because at the exam we should see your face. When you begin to answer, you need to show the document which can prove your personality. So it can be your credit book or it can be the pass, because the system should fix your name, surname, date of birth, and so on. Also, if you do not have any document which can prove your personality, we can ask the group leader who can say that this student is a student of my group. If no one can prove that you are the person who is getting education in this group, we won't have any ability to speak with you, because once again at the exam your personality should be proved. Your ticket will have 2 theoretical questions and 1 clinical case. Today we will speak about cases, shortly about the question and direct answer which you should give. For each question in the ticket, because you have in total 10 minutes, you can waste something like 2 minutes and a half or 3 minutes. Because please pay attention that your examinator can ask you additional question. All these questions and answers should be in time of your direct answer to each question. You can look at the schedule of the oral consultations at the DL section of .ru, and you will find that for the groups, let me look. For example, groups from 68 to 71 goes tomorrow to Professor Blinova and so on. So if you can't find that the contacting community or here in Discord, you should always go to the DL section of .ru and proper information will be presented there. So let's start from the very beginning, and our first question is about patient who is so all okay, yes. So if you predict that you can have the problems with the internet before the exam, some like before few days, you should write to your international dean office and inform the staff that you can. Well, if you look, the system recognize you that you attend the class, and if you suddenly go out, it means that your session is cancelled. For this case, you need to make the print screen of your computer screen, and you need to screen the condition of your internet connection and send this information to the dean office. And then they will open you a new session, maybe in another day. Because automatically it means that you didn't pass if you decided to go out from the cyber class. That's why we are all asking you to use the laptop or personal computer, but not the mobile. The mobile internet is usually not perfect. Mhm. Okay, let's go back. And you see the first question. This is the first clinical case. So we can find that the patient has complications because of the abduction of his arm to the horizontal level. The problem is in this task, it is mentioned about fracture of the humerus, which occurred 3 months ago. Well, the question of this task is to explain what can happen, and maybe the additional question of your examinator can be, please explain the level of the fracture and explain the topography of the nerve, because we need to show that the proper nerve supply of this region is the axillary nerve. And I will wait. Mhm. So we speak all about surgical neck of the humerus, and we should look at the back side of the upper extremities and the humerus bone, where we will find the axillary nerve. First of all, the projection is between clavicula and scapula, and then it passes directly down, makes some like a circumflexion around the scapula, and then it goes below. To make the projection of the different branches, you see the superior and inferior branches, which mostly located at the posterior side of the humeral bone. After that, additional answer to this question will be that the first level is located somewhere around the surgical neck or surgical column of the humerus, and additionally the damage was directly done to the axillary nerve. Your examinator can ask about additional sensation of this nerve, and you can say that your patient maybe has some dissensitive for the skin, because we know about cutaneous branches of the axillary nerve, and we also know about motoric nervation of this area by the once again axillary nerve. If you answer in a proper way during 2 minutes and a half, maybe one more additional question can be asked: what should you do for this treatment? And you need to say that you need to make the reconstruction of this fracture. You need to mobile the parts of the bone in the direct position and make the decompression for the nerve. So this is the answer for these parts of the question. Another clinical case. Is it understandable? Is it enough for understanding? Okay. So the another question, uh, you can make this photos of the screens, because at the left side of the screen you can find the proper answer to the question. So the second case is about ovarian cancer, where the surgeon should ligate the ovarian artery. And first question is about the internal landmarks for the artery, and another, which structure we should protect when we do this accidental ligation. According to this, you need to speak about ovarian location. We know that it is located in the small pelvis, and so we speak about female version. And it is located, and the landmarks are the fossa ovarica. So the projection above will be the perineal layer. And after that, we can find with you the postomedial vessels, like iliac vessels and the internal iliac vessels. So this is the most important which we mention in this task. Well, and the ligation and the protection of this accidental procedure is to protect the ureter and not to be the case of very strong bleeding. So the answer to the internal landmarks of the ovarian artery is, firstly, we need to find the fossa ovarica, and we need to find the peritoneum, which covers the parietal part of the pelvis. Secondly, we need to focus at the ureter, which shouldn't be damaged during your procedure. So this is the answer to the question about ovarian cancer and about the ovarian artery. In addition to this question, if you do not explain that, once again, you see the fossa ovarica and you pay attention to the peritoneum, the question can be about the structure of the uterus and which part it has and which part is once again covered by the peritoneum, and you can say that the upper medial part. After that, we have another question. It is about the radical mastectomy by Holstead, and the question is about structures which should be removed during operation, and you need to give that topographical explanation of the actions what should be done by the surgeon. So the Holstead operation, we know, is called radical because it removes muscles totally. We speak about big and small, or great and lesser pectoral muscles. Also, it removes the axillary fatty tissue, and in addition, because all lymphatic nodes are included to the structure of the gland and fatty tissue, we need to remove 5 groups of axillary lymph nodes. So, additional questions and the explanation of the complication of this operation is that at the site of the operation, because we removed all lymphatic nodes, we can find the lymphostasis for the upper extremities. So as prevention to this disease and clinical presentation, you need to speak about recommendations to the patient that he or she, mostly she, shouldn't do any physical activity at the right side. Now we speak, or at the left, okay, at the site of the operation. Because if we do any physical activity, the muscles make pressure to the lymphatic vessels and lymph nodes of the 3 upper extremities, and because there is no connection between lymph nodes of the axillary fossa and axillary area and upper extremities, the lymphostasis and edema of the upper extremities can happen. So the explanation is, firstly, you should speak about structures which are included to the radical mastectomy by Holstead, all muscles, fatty tissue and lymph nodes. And then you speak about lymphostasis as complication of this operation. In addition to this question, you can be asked about modification of the Holstead technique. We call and we know this operation as modification mastectomy, or by name, by Patet technique. It means that we remove only greater muscle, and we can make the special layer for the transplant, for the implantation of the mammary gland for some cosmetic decisions. But this question is very simple because it speaks only about few steps of operations. You do not need to speak about stages, about instruments which you should use, but only the proper answer about muscles, fatty tissue, and axillary lymph nodes. As a simple addition to this question, your examinator can ask, where is the location of the mammary gland? Which part of the body has it? Well, next question is about inflammatory process, which is located and presented as the phlegmon of the posterior region of the thing, which can be accepted by the surgical treatment. According to this, let's go a little bit deeper. And before we give the proper answer about transfer of the pus, which can go through the muscles to the different compartments, and before you give the proper explanation, do you remember why in the gluteal region this phlegmon or previously the abscess can happen? What should be done in the wrong way to create this inflammatory process? What medical procedure can be the case of this condition? It was a question. If you keep silence during your exam, usually it means that you know nothing. Once again, my question is, what medical procedure can create this complication? The phlegmon of the posterior region and the phlegmon of the gluteal region. Do you know? Okay, some unknown procedure. Okay, the topographical explanation to this case is to speak firstly about sciatic nerve. And you can see that the sciatic nerve is the most is the biggest nerve, which goes through the gluteal muscles along, and it goes to the anterior compartment of the adductor muscles. So here we see the sciatic nerve. And because the nerve goes in the condition of neurovascular bundle, the pus can go along below, and in some cases it can go upper to the structure of the pelvis. So the proper answer to this question will be the pus can go below and under the gluteal muscles, and the direction will be the projection of the sciatic nerve, which can be the transfer to the compartment of the adductor muscles. So additionally, we will find there the circumflexofemoral artery, because it can be the branch and it can be the part of the neurovascular bundle. I'm sorry. Алло, у меня... Okay, let's go nextly. And the case of the phlegmon and abscess will be the injection to the gluteal region because you need to remember about areas which are safe for injections and areas which can be damaged. During this presentation, you have to speak. It's not enough only to be visitors for those who are just looking at funny pictures. If you do not discuss, it means that you understand maybe nothing. Well, the next question is about inferior tracheotomy for the phlegmon, which is located in the superior and anterior mediastinum. So the question is the ways for the infection and the ways of pus transfer. To answer to this question, you have to remember the organ which is involved to the operation tracheotomy, where we make this procedure. Once again, it's a question. Do you know where we should perform the tracheotomy? Do you have any ideas? Do you know how to speak? Okay, some operation which happens somewhere where we do not know. The inferior tracheotomy and the inflammatory process, which can be the case of different complications, is located between, first of all, please pay attention to the prevertebral fascia. It is here. After that, we have the prevertebral space, and we have also retropharyngeal space. All of these structures can be involved to the inflammatory process, which is located behind the trachea, the area of the tracheotomy operation, and the inflammatory process can reach firstly to the retropharyngeal space, and it can go up to the mouth cavity as additional complications, but mostly the inflammatory liquid and pus goes to the prevertebral space and go below. If it goes below through the prevertebral fascia, it goes to the firstly superior mediastinum. It is here because it has the direct connection with the esophagus and the prevertebral space. And additionally, we can find the involving of the anterior mediastinum because it's a little part of the superior mediastinum which goes directly below between sternum and the anterior surface of the pericardium. So the explanation of this case is that we have the phlegmon behind the trachea, which can go down to the superior and anterior mediastinum, and additionally, it has the connection with the spaces of the neck. You need to revise the structure of the mediastinums to give the proper explanation to this question. Another clinical case is about the non-operable cancer of the rectum, and you need to explain how to help the patient because of the intestinal obstruction. So I will try in another way to ask you how you understand the intestinal obstruction. I will stop at this clinical case and I won't go to others before you start any conversation. It's, it's not a lecture. Again, it's not a lecture. It's a time for discussion. How you understand the intestinal obstruction?
Maybe
What
if it's
is
in
intestinal
cancer, maybe
obstruction?
there's a tumor blocking
What
the
is
intestinal.
intestinal obstruction?
If it's cancer, maybe it's a tumor that's
Does it
blocking.
mean does it mean that it's blocking the intestine? Is it something
Where?
like that?
Where?
It might be food. When you're
What?
digesting food, it might be blocked in the intestine or in the stomach.
The question is where? Where means the location.
Um,
All structures which are above the rectum can be obstructed because we know the location of the tumor. It is set in your task, the cancer of rectum. That's why you need to make the connection between small intestine and the gaster, between the artificial anus. So you need to create this pretransversal peristaltic gastroiunal anastomosis. So it is here. It means that you need to make the direct connection between gaster and outside to put the stoma where you can collect the food and the structures which are presented in the gastric tract. It can be done if we have different cancer of the rectum or as a presentation here, cancer of the gaster or stomach. So the idea of the bypass and connection between gastroiunal anastomosis, it means that you connect the gaster and the iunal. Also, you put the stoma outside to the abdominal wall, somewhere here or here. It depends on the clinical case. And the explanation is the firstly, you need to make the anastomosis between intestine or stomach with the outside surface of the anterior abdominal wall. So you need to ligate the intestines which are above the rectum, and you need to disclude rectum from the digestive tract. The idea and the steps of operations are very simple. Once again, you need to make the laparotomy access, and you need to make the connection between in and outsides. So we do not ask you to explain the special instruments and stages, but you need to, in general, speak about this anastomosis. Well, the other case, which presents, you can, you should do any operation which can help to transfer food from the stomach to the some artificial area. It once again can be the stoma, which can be created and the anterolateral abdominal wall, or it can be like artificial anus. But for the artificial anus, it's not a very good condition because we know that rectum is totally damaged. And at the site of the rectum, it will be impossible to make any additional anastomosis. So you should put it to the anterolateral space. Well, additionally, the seventh ticket and the seventh clinical case is about injury to the superior wall of the urinary bladder. And the question is firstly about the operative access and what should you do and how should you treat your patient. In addition to the answer to this question, you need to speak about firstly, you need to know about the midline laparotomy. So it is making somewhere here. Also, you need to remember about the peritoneum, which can cover, let's draw it in this way, which can cover the upper parts of the organs which make the floor of the pelvis. And through this inferior midline laparotomy, you need to use the suturing of the damaged wall of the urinary bladder. You need to pay attention that we use 2 row sutures because we are not going to damage the structure of the urinary bladder. Please pay attention that we have few layers, and especially we shouldn't damage the mucosa which covers the internal structure and the internal surface of the urinary bladder. Where is the landmark of the inferior midline laparotomy? How should you find, which bone you should find for this operation? Which bone should be the landmark of your operation? Once again, it was a question. Do you know the answer about landmarks of the inferior midline laparotomy? If you do not answer to such question during your exam, please be sure that your mark will be maybe not higher than satisfied. If you keep silence after some answer or reading of answer which is presented in your study book, well, it's not the good style, because you need to remember about the pubic bone, the landmark for this operation. So next, we can find additionally question about the Antarian compartments and the patient with the phlegmon. So the question is about the Antarian compartment of the thing which has the phlegmon, and you need to explain how the pus can go to other regions. And first of all, we should find the adductor canal, and we need to find the iliac fossa and the projection of the lesser pelvis. So the explanation of this question is that the pus can go firstly through the channels of the big blood vessels. We know that the neurovascular bundle can be the promoter for the pus, which can spread below. Then we can find the circumflex femoral vessels, and it can be the transfer to the medial compartment. And additionally, the pus can go inside, somewhere it is located somewhere here, for example, and it can go inside to the lesser pelvis. That's why you have the answer to the question, if we have the phlegmon in the anterior compartment, it can go firstly through the circumflex femoral arteries to the medial compartment. It can go through the iliac fossa or to the lesser pelvis. Additionally, we can use the adductor channel to the femoral and deep regions. The additional question at this case can be about the topography of the anterior compartment, and you need to speak about very simply about if it is anterior surface or posterior surface. And in addition, when we discuss the transfer to the medial compartment, you need to speak about the projection about circumflex femoral vessels. So you can say that it can go below and back to the medial side, below and back to the lateral sides, mostly to the medial because it's smaller than the lateral. About lower extremities, we have additional questions, and we will finish with the lower extremities, and then we will go back to other cases. So another question is the very simple, is about, once again, fracture and trauma of the perineal region. Well, we know from the examination task that during football match, the football player has received a trauma and fracture of the neck of the fibula. And now he has some clinical cases of the plantar flexion, and the question is about the injury of the nerve. It looks like the same question about the axillary nerve when the patient got the injury, but here, once again, we go back to the lower extremities, and you need to explain the symptoms and the place of the injury. It is presented in the clinical task that the neck of the fibula, and according to this, we can find this region at the picture. That's why the explanation for this task will be: we have the injury of the peroneus communis at the superior musculoperoneal channel. It is here. So the first question, the injury is the peroneus communis, and then which symptoms can go as the signs of the injury. It means that we speak about peroneal muscles and the anterior muscles of the leg. So we speak also about different branches which give the sensoric innervation to the skin and motoric innervation to the muscles. So you can describe the area of innervation and branches which goes from the peroneal nerve. And in addition, you speak about the compression and some damage for the nerve properly. The additional question to this case can be about the topography of the peroneus communis nerve, and you need to speak that it circumflex the posterior side of the femur, then it goes below through the popliteal fossa, and it goes to the medial side of the fibula in front of the column. So in case of any fracture, you see the big trunk of the nerve can be damaged, and all superficial and deep branches and belows, like peroneus nerves, which are long and brevis, can be also damaged. The structure of the nerve, if we go to look inside the popliteal fossa, you see it's between biceps and semimembranosus and semitendinosus muscles. It's very deep. It goes through the fossa below, and then once again it circumflex the fibula. And the explanation, once again, is simple. You speak about peroneus communis nerve, and you speak about peroneal muscles and anterior muscles of the leg. Nextly, we go to the neurocranium, and the question is about squama of the temporal bone is also injured easily and more frequently than the other bones of the cerebral part of the head. So the task of this case is to give the proper explanation why the temporal bone is injured in many cases, and what should you do to explain the topographical substance of possible complications. Please look at the X-ray. And we easily recognize the temporal bone. We can find the petrosal part, like a pyramid of the temporal bone. We can find the projection of the mastoid process and labyrinthitis and holes inside. And additionally, we see this very, very thin part of squama of the temporal bone. And you can explain, first of all, inside we have the structure of the brain, and inside we have the internal lamina, also call it glass lamina. And you can see that if we have some damage to the bone, like I don't know, some injury, the parts of this bone will be very sharp and will be very thin. That's why they can easily damage the middle, the arteria meningeal media or middle meningeal artery. So the parts of the bone can be the case of bleeding, and they can create the epidural and subdural hematomas. And according to this, your explanation will be, first you speak about the quality of the bone. It is very thin and it goes to this internal lamina. And then if we damage this bone, we can damage the arteria meningeal media. So next, with already 10 clinical cases, all of them are presented in your examination tickets, and if you answer in a proper way, you can easily solve it. Usually, in examination tickets, we have questions from different parts and different topics. Some like one question from the head, one question from the abdomen, and one question from the lower extremities. But you will never find the same topical questions in one ticket. Another clinical case is about the acute appendicitis, which can be the complication of the inflammation of the peritoneum in the same name rhesus. Well, the question is about the rhesus and localization. To answer to this question, you need to speak and you need to revise in your memory about topography of the appendix. It is here. And additionally, we speak about iliocecal rhesus. Once again, it is here. So this very acute angle between the appendix and the intestines. So it includes the triangle, and in this rhesus we can find the pus, which can be a case of the general peritonitis or acute appendicitis. To explain the location, you should speak about once again, the internal margin of the ileum and the surface of the ascending colon. Here, in the connection of the connective tissue and blood vessels, we can find this rhesus. Well, this is a very simple explanation how the acute appendicitis can be complicated and how the pus can go out to the peritoneum. Additionally, please look at the picture at the right side of the screen. It gives the proper explanation how the inflammation can be delivered to the different parts of the abdominal cavity. So if we have inflammation below, somewhere in front of the appendix or in front of the cecum, let's draw it here. You see that it can go below to the uterus, it can go below to the ovary, it can go below to the rectum or to the urinary bladder and prostate in the male case. But if we have some inflammation below below the gaster, somewhere here, the nature of the transfer can be by the ascending colon to the right paracolic channel, can go here. It can go upper to the bursa hepatica, but it shouldn't, and it will never go to the opposite side because we have the mesenteric here. This picture can be additional explanation for the other tasks when we have inflammation inside the abdomen. And once again, the explanation to the question, your question was about acute appendicitis, which can be complicated, is the rhesus between the colon, as this ascending colon, and the ileum. So you see this very acute area. Nextly, this question is about the access to the forcation or bifurcation of the common carotid artery. To answer to this question, you need to revise and then you need to explain the location of the bifurcation of the common carotid artery, where you can find it, which thoracic vertebra or which cervical vertebra is the projection of this region, where. You can find that above we see for the internal artery the C3, then the furcation is located where? Where? Which cervical vertebra is the projection of the furcation of the carotid artery? Where? If you speak a little bit louder, it will be maybe
cervical ansa, like it's written.
My question is about vertebra. Why answer? C means cervix and V is vertebra. It's a very simple and very typical question about neck, the projection of the furcation of the carotid artery. It's already written that in the anterior part we can go to the superior margin of the thyroid cartilage. And where is the projection of the thyroid cartilage at the vertebrae? Which vertebrae are involved to these structures? If you cut the head from the neck, here, which vertebra you will damage? Anyhow, the proper question, the simple answer to this question, which vessels and nerves are involved to the presentation, is the jugular vein, for sure, internal, the superior rootlet of the cervical ansa, and vagus nerve and its branches. But once again, I think some examinators will also ask you which vertebra we can find in front of the furcation. It's very simple. It's from the human anatomy, from the first year.
Maybe atlas vertebra.
Atlas vertebra. Do you know the number of the atlas vertebra? So you think that the projection of the furcation is in front of the occipital bone? We speak, please remember that we speak about human anatomy, not animal, not extraterrestrial, not some dinosaur, but we speak about human. Let's go next. C6, C7. If you're going to answer at the exam in the same way, you will get totally unsatisfied. You are answering, okay, what about the others? We see how intensively you type in the Vkontakte community. But when you have a possibility to speak, you keep in silence. That's very strange. Another question is about the Borne Abscess, which is located in the second interdigital space. And we see that the pus is spreading into the commissural opening of the palm. So where is the palm? Where is it? How you understand the palm? Okay, do you know what is palm?
It's like part of the hand.
Which part?
Anterior.
Okay, as you see at the clinical presentation, this is the cadaveric material. We need to speak about the palmar aponeurosis. The palmar aponeurosis is located in the internal surface of the hand. So it is here. It's like a Latin letter V, and it has different branches because it goes to the fingers. Especially we speak about 4 parts of the palmar aponeurosis, which goes to the second, third, fourth, and fifth finger. Additionally, below in the border between the hand and in the carpal region, we have another branch which goes directly to the big finger. That's why this is a very big difference in the transferring of the pus. So we can find that it can go to the dorsal side of the proximal phalanx because of the arch which goes inside the hand. And the answer to this question, when you need to speak about firstly layers of the localization, you need to say that it is under the aponeurosis of the palmar of aponeurosis. Another answer to speak about ways of the spreading of the pus, you can say that it can go via parts of the palmar aponeurosis inside to the fingers, and also it can go through the blood vessels which are created by the big arch of the hand. It's a very simple question about only hand and arch and aponeurosis. Then we have another question about head. And the question is about the purulent parotitis and how to treat the patient and explanation of the pathway for the pus. We need to revise that the parotid gland has a very serious structure inside. It has the trunk of the facial nerve which goes through the structure of the parotid gland, and also we have branches which goes directly to the muscles of the face. And especially for the parotid gland, we know that it has 2 capsules. It has external capsule and internal capsule. And this capsule has weak places. Weak places means that the part of the border is very, very thin. So first weak place is located in front the porus acousticus externus. So the external meatus is the place where the pus from the parotid gland can go out. And second, very weak place is located at the medial surface of the gland. It is here inside, in front of the pharynx, so the inflammatory liquid and pus can go to the peripharyngeal space, somewhere here. And usually, in most of cases, the second weak place in front of the pharynx is damaged. But in some conditions, especially when the inflammatory process is very rich, it can go to the external meatus of the ear. How to help the patient? You can go, first of all, you need to recognize which place and which part is damaged according to the palpation, and then you need to make the incision through the mouth cavity if we speak about the peripharyngeal space, or you can cut through the skin, but the direction of your incision should be oriented to the branches of the facial nerve. If you damage these branches, some muscles of the face can be also collapsed. Then we go below and we are in the abdominal cavity. And the question is that it is very necessary to perform the anastomosis between the posterior wall of the stomach and the loop of the small intestine. And you need to use the amental busa or the lesser amentium to move this loop. So which side or which wall of the amental bursa of the small amentum we should use. We need to use the inferior wall of the amental bursa. So if we know that we have two sacs, like lesser and bigger, the lesser we know also as amental bursa, we can find that it is located posteriorly to the stomach and the lesser amentum. And the orientation is, please look to the amental bursa. We can find that it has the special opening. We call it epiploic foramen. And additionally, the epiploic foramen is situated posterior to the lesser amentum. That's why the answer, we should go through the inferior wall of the amental bursa if we are going to make this anastomosis between posterior wall of the stomach and the small intestine. To answer to this question, you need to speak again about amental bursa. Where is it? The topography, very shortly, that it is located posteriorly to the stomach and lesser amentum, and then about the inferior wall of the amental bursa. So it's a 2D picture, but please look, the inferior wall of the amental bursa is located here. It is very close to the small curvature of the gaster. Then, additional question about the stomach and the duodenum is because of the resection of the stomach because of the injury of the common bile duct. Well, the question is during which stage of the operation it can happen. And another, the topography of the common bile duct should be considered during your planning where you need to focus your attention. We know that the retroduodenal parts of the common bile duct it has the location somewhere in front of the pyloric part of the stomach. So it is very here. Please look. Very small and distending part of the duct. In front of the bifurcation, from this part we will find the duct which goes from the pancreas. And if we make the mobilization of the duodenum, you need to remember the operation, the revision of the abdominal cavity and Gubarev's method, when by left hand you take the part of the gaster and the sac and evaluate it up. In this case, you can damage the duct because it's very, very thin. And if you make the pressure at the surface of the duodenum, you make the pressure also to the system of the duct, and you can be the case of fracture between sides of the duct and side of the duodenum. So the explanation for this clinical case is the answer for the topography of the retroduodenal part of the bile duct. So you speak about right pyloric part of the stomach, and the possible stage of the operation, the answer is the mobilization of the duodenum. Well, next, we speak about the hernias, and we discussed it during thorax lectures. So the question is about the hiatal hernia. At the cadaveric material you can find, so please look, at the right side here we have the heart, all of us. Then I will change the color, maybe it will be better to observe. The green line shows the esophagus, and then the lower part is presented by the diaphragm. So the patient was complicated about heartburn and pains in the epigastric region during the long time. At the X-ray, we can recognize the hernia of the esophageal opening of the diaphragm, and you need to give the topographical description of this hernia. So the very simple parts, the very simple question is, because we speak about the diaphragm, we know the foramen, the esophageal foramen, which give the transfer of the esophagus to the abdominal cavity. And in this area, we have a very weak place. That's why this hernia goes through the esophageal foramen or opening to the diaphragm. And when the diaphragm, we know, is very thin but very strong muscle, make the pressure, we see this hiatal herniation above. And also, we can see the phrenic nerve, which goes through the internal surface of this herniation. And the pressure which is making to the heart give this heartburn and pains in the epigastric region. Additional question to this case can be, how are you going to treat the hiatal hernia? Which very simple operation you need to perform to treat this patient? How to treat? My question is how to treat. Do you know the title of the operation which can help this patient? We discussed it during our thorax lectures, and the title is Nissen Fundoplication. Fundoplication means that we make the circumflexion of the part of the gaster and we suture it inside the gastric wall. So you make some like a protection for the esophageal opening, and it protects the esophagus to be hiated in the thoracic part. So the idea of this question is to give the explanation that the hernia can go through the weak esophageal opening to the diaphragm, and it can make the pressure to the phrenic nerve and especially to the heart. That's why patient has pain. But in case your examiner asks the operation which can treat your patient, you need to speak about Nissen Fundoplication. We discussed with you about topography of the organs of the neck, and my question at the last case was about which organ is involved to the tracheotomy operation. I hope that already now you can imagine which organ and where we should perform the tracheotomy. But this question is about the foreign body in the cervical part of the esophagus, which can be removed during esophagoscopy. And you need to speak about the landmarks which can be used during operative approach to the cervical part of the esophagus. So where in the neck we can find the esophagus? Can you speak about level? This is a question. Everywhere for the neck and for the trachea, we should speak about projection at the vertebrae. So what about the cervical part of the esophagus? So from 6 and 7 cervical vertebra to the first thoracic vertebra. This is the projection of the cervical part of the esophagus. What about the thoracic part of the esophagus? Where is it? There are 13 students in this voice channel. Only one speaks. So what about abdominal part of the esophagus? Anyone knows? Where is the projection of the abdominal part of the esophagus at the vertebrae? Do you know? From 10th to 12th. So the answer to this case, you need to speak about the landmarks are larynx, then we have trachea, and the projection of the tracheoesophageal groove at the left side. Additionally, we need to speak about the nerves as branches of the vagus like a recurrent laryngeal nerves. So can you recognize? So this is the esophagus, then we have trachea, above we have thyroid glands, and especially about thyroid gland will be our next clinical case. So we need to discuss the subscapular and subtotal resection of the thyroid gland by the Nikolaev. And it is presented that we should leave the posterior parts of the lobes and keep it intact. And the question is why, and you need to give the proper substation and the explanation how this operation is managed. To answer to this question, first of all, please tell me about where is the location of the parathyroid of the parathyroid glands. We have thyroid gland, the main, and we have additional parathyroid glands. So where is the location?
Located behind the lobes in the parathyroid fatty tissue, because it's already written over there. Or am I mistaken? Where? What? I didn't hear you, teacher.
My question is about parathyroid glands.
Yes.
Where is the location?
Ah,
In front of thyroid gland, like
Where?
in front, around the thyroid gland, under it.
No, not under.
Posterior.
Where exactly?
behind the lobes.
No. So
Fatty
the
tissue.
idea by the Professor Nikolaev was very genius because before it was made some like in the middle of 20th century. The operation at the thyroid gland was total. So all capsules, like internal and external capsules, were removed. The thyroid and parathyroid glands were also removed. The idea of the Professor Nikolaev was to go inside. Please look, we have two capsules. We have false and we have true capsule. The idea was to go through the false capsule, open it, to remove the most part of the thyroid glands. But we know that the posterior part of the thyroid gland has not only the parathyroid glands at its surfaces, but also it has the very close connection to the, please look here, to the nerves. We have a very close location to the recurrent nerve. And if we damage and if we remove the thyroid gland totally, we will damage the laryngeal nerve. And what can happen with the voice of the patient? If we damage the recurrent nerves, What can happen with the voice?
He cannot talk.
For sure, but why?
Because it's close to the vocal.
Perfecto. It is very close to the vocal cords. That's why the idea of Nikolaev was not only to save the parathyroid glands, but also it's a very good ability for those who has vocal professions like singers, speakers, I don't know, teachers, and so on. And additionally, you should know that it's a very great strategy when you lose your voice, when you can only type. Imagine, it's a very big problem for patients and a very great stress. So the explanation for this case is that we should go inside the false capsule. We should remove the. We should go inside the true capsule, and then we can remove the gland, and we can leave the posterior surface, which is included to the true capsule surface. That's why the explanation of the operation is subcapsular. It means that we go, please look, subscapular. Firstly, we go through the false capsule. Subtotal, it means that we remove only some part of the gland, and for sure, resection is the operation when we cut. So if we look at the second part of the screen, you can find, I will draw the green line. It will more or less explain how we make this procedure. So the most part of the gland is removed, and the parts, the posterior, which has the connection with the parathyroid and recurrent nerves, is saved. If we go shortly back to the question about the phlegmon in the because of the inferior tracheotomy procedure, please look. We have two types of the tracheotomy operation. We have, it will be inferior one and superior one. When we make superior and inferior, for inferior, we mostly use in kids because of the structure of the trachea. For adults, we use superior, and we should go to the cricothyroid ligament between thyroid cartilage and the isthmus of the thyroid gland. If we damage the isthmus, a very huge bleeding can start as the complication of the tracheotomy operation. And please look here at the second picture, you see the esophagus, which is located behind the trachea. So the phlegmon, as the complication in previous question, starts between trachea and the esophagus, and it goes below through the projection of the esophagus at the cervix, and it can reach the thoracic cavity, it can reach the abdominal cavity. So if you know the organs of the neck, you will easily explain all questions which are presented in our tickets. And lastly, the same clinical case, it can be paired in your question, is about, once again, the squamon of the temporal bone. The explanation is the same, but I decided to make additional pictures for you to show why it's very dangerous to damage the temporal bone. Please look inside. Here, in this part, we have the temporal bone, the internal surface projection. Additionally, the explanation for this task can be which operation you can perform to treat the epidural and subdural hematoma. The epidural and subdural hematomas are located above, like in case of epidural, or below the dural space. So we have a very thick structure as dura mater, which covers the structure of the bone, of the brain, I'm sorry. And the blood can be above and below. To treat the hematomas of the cranium, you need to make the trepanations. Do you know which trepanations we should do? Do you know how to classify the trepanations? Do you know the classification of trepanations? Once again, it was a question. Do you know something about trepanations? How to manage the trepanation? So if you look at the screen, you will find the pictures of the osteoplastic trepanation. We have two types of trepanations. We have simple and we have this osteoplastic. The idea is to, please look, we need to make the ligation for the lots of numbers of small blood vessels. That's why at the picture you see such a huge numbers of operations and the mosquito clamps. Then you need always to remember how should we cut and make incision at the head. Please look, this semi-round excess and the layer is going below. Why this direction is typical for this operation? Because the projection of the temporal artery, please look, it goes from the lower part to the upper part to give lots of branches. That's why if we cut in direct way through this branch, we will get the very huge bleeding from the temporal artery, from the area of the external carotid artery. That's why we cover it below. Then we should cut the dura mater and arachnoid mater of the brain and make the proper access to the brain. After that, we put it back layer by layer. And the osteoplastic trepanation, the idea of this modification is to save the bone. You see it is drilled by the rotating instruments and by the handy saw. We have a few holes from the 3 to 5, and after that we should use the provider which can protect the dura and arachnoid mater from the saw. We connect these holes and took the bone out. After that we make operation at the hematoma and then we put it layer by layer back. So you have lots of presentations in your Discord and at the Vkontakte community. All of them, please look, they have questions from your exam tickets. So if you read it carefully and make short answers to each questions and additionally to the clinical cases which we discussed today, you will got a very good mark. What? No, it was a presentation for today. All presentations of clinical cases and questions are presented in the PDF files which are in the Discord and Vkontakte community. It was only about clinical cases, but it's more or less the same. It's clinical cases, the third question of your ticket. We will have additional time for all of us who are English speaking, Professor Blinova and me, we have additional time, I think, on Tuesday. If some of you will find additional questions, you can connect in the time of the online consultation and ask. But the idea of our community now is to discuss, but not only to listen. Sorry. Дались. Не консультация.